Welcome, everybody, to the fourth session of the day, Systems Improvement Efforts for Diagnostic Excellence. I'm Kathy McDonald. I'm from Johns Hopkins, and I'm co-moderating with Laura Evans. We have a great session planned for you and are grateful for our panelists. We have, kicking off, we'll move quickly to that point because we know that we're getting later in the day and it's wonderful to spend time on the content. Our first panelist today is Hallie Prescott, and she's joining us from University of Michigan, where she's an assistant professor in pulmonary and critical care medicine. She's also a staff physician at the Ann Arbor Veterans Affairs Hospital. She's an expert in long-term outcomes and recovery from sepsis, and her research includes quite a bit on quality improvement collaboratives, which she'll be discussing today, among other things. We're really glad to have her here. And Hallie, I'm going to kick it off to you to start.
Great. Thanks for the introduction, and thanks to the organizers, the National Academy, and the Moore Foundation for the invitation to be here. It's really an honor, and I've enjoyed all the talks this morning. Next slide, please. Here I've just listed my current funding related to sepsis and performance measurement, relevant roles. I have no financial conflicts. I'm just obliged to tell you that these are my views, not views of my employers, the US government, or the Department of Veteran Affairs. Next slide. So in my 10 minutes, I'm going to just briefly talk, since we've talked about this a bunch already, but the challenges that clinicians face at the bedside in terms of real-time sepsis diagnosis. I'll talk about how continuous quality improvement collaboratives can help improve, but probably not perfect, diagnosis at the bedside, and why we must embrace diagnostic uncertainty into our clinical decision-making. Next slide, please. So I'm just going to quickly cover three different studies that all really tell the same story, that it's difficult and that there's a lot of disagreement about sepsis at the bedside. So this is a study that surveyed about 100 different intensivists. They gave them 4 different vignettes, and you can see that there was consistent disagreement across the clinicians in terms of whether the patient did or did not have sepsis. Next slide. This is another study, used slightly different methods. So this looked at all patients admitted to 2 different intensive care units who had a tentative diagnosis of sepsis at the time of ICU admission. They then had clinicians review the case at the time of hospital discharge to say, in hindsight, how likely was it that the patient truly did have sepsis at the time of ICU admission. They found that for about 13% of the cases that there was no chance that the patient had sepsis in hindsight based on everything that was subsequently learned. In an additional 30, it was possible, as opposed to probable or definite that the patient had sepsis. Next slide. And then most recently, there was this study that looked at code sepsis activations among ER patients across a 10-hospital system. And they found that over the 9 quarters of the study that there was about 43% of all code sepsis activations turned out to be false positives based on, again, what was subsequently learned during the course of the hospitalization, physician review, diagnosis codes, et cetera. The other thing I'll point out here is that they had a quality improvement work to try to increase the identification of sepsis in the ER. You'll see across these first few quarters that the number of true sepsis activations does indeed go up, but as does the number of false positive activations over that same time frame. And I think that that is something that we will see consistently in quality improvement, is as you push one thing, you may improve both appropriate but also inappropriate diagnosis and treatment. Next slide. So I think with that background, consistently we see that clinicians have difficulty or disagreement, uncertainty in terms of sepsis at the bedside. I'll now talk about continuous quality improvement initiatives and how we can use these to try to nudge forward diagnosis and treatment. I'm the physician lead for sepsis initiatives for the Michigan Medicine Safety Consortium, which is currently about 50 hospitals participating, will ultimately grow to about 70 hospitals in the next couple of years. I'm also on the steering committee of the My COVID-19 initiative, which is a quality improvement initiative related to coronavirus hospitalizations that we launched at the end of March. So for this quality improvement work, we use very granular data collection that is done by humans, professional abstractors who are actually paid by Blue Cross Blue Shield to be in each of our member hospitals and collecting data from the medical record. We then collect that information locally at University of Michigan, where we then analyze the data and we provide audit and feedback back to all of the member hospitals in our CQI. We additionally do education through quarterly meetings, and we'll frequently invite hospitals that have had good success or improvement in their metrics over time to sort of share what it was that they did locally to bring about that change so that other hospitals can learn from their stories. Next slide. A lot of the work historically for this CQI has been around antimicrobial use, ensuring both the appropriate and timely treatment of infections such as urinary tract infections, pneumonia infections, as well as simultaneously trying to avoid overdiagnosis or overtreatment of these conditions. So here I'll just show you an example. One of the things that we have focused on is reducing the treatment of asymptomatic bacteriuria. And here you can see over about a 3-year period that we've had substantial reduction, about a 50% relative reduction in treatment of asymptomatic bacteria. The specific metric we're using here was the proportion of all positive urine cultures that turned out to be treated in asymptomatic patients. Next slide. The improvement in this particular metric can occur through 2 mechanisms. The first is reducing testing. So if the patient has no signs, no symptoms to suggest urinary tract infection, the patient is not critically ill, they didn't really warrant a urine culture in the first place. And so that's one thing that we will track over time. The other is reducing the treatment among people who, still had a urine culture collected. It turned out to be positive again, but they still didn't have signs or symptoms of a urinary tract infection or any kind of markers of critical illness or immune suppression, et cetera. And so you can see that really a lot of our improvement has become from the reduced testing. It's been sort of harder to move the needle in terms of once that culture gets collected and it gets resulted to the clinician, that seems to be sort of a harder behavior to change. Next slide. So a couple of the lessons, and I think this really echoes the prior panel, but a couple of the lessons that we've learned is that CQIs can improve the diagnosis, appropriate treatment over time. We can use this to both leverage appropriate treatment, but also, as I've just shown, avoiding overtreatment. And one of the things that we found really key is having trustworthy data. And I think that is one of the reasons that we still continue to have human abstractors collecting data in these hospitals, is because it allows us to really focus in on these sort of granular, nuanced clinical cohorts where everyone is going to agree, based on all these different sort of rules that we have in this human abstracted data, that really this patient truly was asymptomatic bacteriuria, and we aren't somehow misclassifying patients who should have been treated. So the hospitals need to have trust in our metrics to be able to drive behavior change locally. And then likewise, we've also found that some behaviors turn out to be harder to change than others. Next slide. Okay, so with that background, I'm now going to spend the rest of my few minutes talking about, can we better embrace diagnostic uncertainty in sepsis? So I've shown you, and you've heard throughout the day, that it's consistently difficult to diagnose sepsis. I think the speaker before me mentioned, that one of the challenges of a lot of QI problems or projects is they just pull people out with a diagnosis of sepsis, but we already know the diagnosis is very uncertain, so then it becomes this sort of uncredible data. It's hard to move behavior change. So I wonder if we cannot sort of bake some of this uncertainty in, and rather than look at sort of sepsis versus non-sepsis patient, think about our patients across 2 different axes. How likely is it that that patient indeed had bacterial infection based on the data knowable in real time, and how sick is that patient when they presented? Next slide, please. And so in this perspective that I published last year, I lay out this framework where we try to suggest differences in the timing and the broadness of antimicrobials depending on these 2 axes, how sick and how likely were they to be infected. And certainly the amount of uncertainty that you will tolerate when prescribing antibiotics should vary depending on how sick they are. If that patient comes into your ER, and it's too sick to guess wrong, you're going to have to treat with antibiotics before you can confirm that that infection is present. By contrast, for people who are much less ill, we should have a lot more certainty before making the decision, and we have the time to do that. Next slide, please. So some of the specific arguments we make here, yes, again, threshold and urgency for initiating antibacterial treatment really should vary across patients. When we use unidirectional measures and only look at the appropriate treatment or the undertreatment, we might drive all of care in one direction. So I think it's important to look at both sides of that coin. Are we appropriately treating the sick people rapidly, but also are we withholding treatment in patients who likely do not have any evidence of infection? Going forward, I think we need better risk models, biomarkers, rapid tests to help stratify people along these axes. But even with better tests, I think that we're always going to have uncertainty in our clinical decision making, and we are able to use even less than perfect risk models to guide our treatment. And there's some examples of how we're actually already doing this in our clinical decision making. So for example, we have other relatively simplistic algorithms or risk models, such as the CHADS-VASC score and the HAS-BLOOD score, which we use to try to weigh what is the likelihood or the chance that my patient is going to bleed if I put them on anticoagulation for AFib versus what is the likelihood that I'm going to help prevent a clot. And we sort of weigh these two different risks to try to personalize treatment for individual patients and also populations of patients to try to overall do more benefit than harm. Next slide, please. So I think that it's hard to know the exact thresholds when we sort of divide these patients, but regardless of where you sort of divide the threshold in terms of how sick they are and how likely they are to be infected, the treatment that patients get across these different strata really should vary rationally in terms of the percent of patients that are initiated in treatment, the time to receive that treatment, and the percent of patients that are stopped early, because we know that if a patient is super sick, we're going to have to sort of tolerate more over treatment, but then at day, at 48 hours or 72 hours, we should be dialing back, narrowing, and stopping treatment when we subsequently find out that infection was indeed not present. Next slide, please. So this is my final slide. I'll just sort of summarize and provide some closing thoughts. Again, studies consistently show these high rates of diagnostic uncertainty. We can leverage quality improvement initiatives, audit, and feedback to improve care, but it's very important, I think, that clinicians and hospitals believe the data and understand the data being fed back them in order to change behavior. We need to work for better diagnostic uncertainty, but I think we also need to recognize that we're never going to have perfect diagnostic uncertainty, and therefore we need to work to implement risk-based algorithms into our bedside, into our quality improvement initiatives, into our performance measurement, as we do, I think, already in other diseases. I think we also need to have better training on clinicians in terms of how do we recognize that we have diagnostic uncertainty, how do we explain that to patients, how do we explain that to the clinicians coming forward, because it really just should be a different sort of trajectory going forward in a patient where, I started broad spectrum antibiotics because the patient is super, super sick and we're not sure why. That should, indicate ongoing diagnostic evaluation to figure out what's going on versus this patient came in with septic shock. Everything is really pointing towards septic shock. We're going to continue to make sure they're responding to those antibiotics over time. So I think that we should do a better job of sort of acknowledging and incorporating this uncertainty into our medical decision making and also communication with other clinicians and patients. I will close there, and thank you guys.